Good evening, everyone, and back to our didactics, 9 p.m. exactly Cairo time. Thanks for all our physical and virtual participants. We are still in the endometrial cancer module, and today is our lecture, I believe, number 16. And today we are going to have a very interesting one about the diagnostic workup for endometrial cancer, how we diagnose endometrial cancer. It will be presented by Dr. Mark Yousef. Dr. Mark Yousef is one of our most active assistant lecturers of surgical oncology in Oncology Center, Mansoura University. And a good thing is that Marco has just said this presentation or presented this presentation in the last course 2 years ago. And now he is going to do the same presentation with 2023-2024's update. So it's very nice when you say the same presentation every year or every other year with the updates. So we are waiting you, Marco. And again, for all our online participants, you can put your questions anytime in the Q&A box, or rather than the chat box. And you can ask to unmute your microphone and speak. We would love to hear your voices with us, either interrupting Marco in the presentation or after the presentation. Thank you, Marco, and the floor is yours.
Thank you to Basil. Good evening, everyone. We are today talking about the diagnostic workup for endometrial cancer. We all know that endometrial cancer is the second most common gynecological cancer worldwide. When both resource abundant and resource limited countries are considered. The most common malignancy in gynecological is the cervical cancer. Endometrium is the second one. To make good diagnosis for endometrial cancer.
Marco, خلينا to discuss again for our ESGO fellows. Cervical cancer is the most common worldwide. Endometrial cancer is the most common in developed countries. Cervical cancer is the most common in developing countries. In Egypt, all the statistics from Egypt show that ovarian cancer is the most common, and we usually say mostly this is because ovarian cancer are usually referred to oncology center where there is registry. However, of course, we are not away from the world, but according to Kubokan and all the registry from Egypt, ovarian cancer is the most common, which I totally believe, and I say it is wrong interpretation of the data, because most cases of endometrial cancer are not referred to oncology centers. Yes.
Not registered at our centers. To make good diagnosis for endometrial cancer.
المايك عشان keep the mic for our virtual participants to hear you. Okay.
We should do what we always do for any disease, a triple assessment. Clinical presentation of the patient, by radiological investigation and pathological investigation. Why we do this? To reach proper diagnosis, proper staging, then to apply the proper management plan. Suspected case of endometrial cancer, we should consider age, complaint of the patient, and proper history taking, physical, radiological investigation, and we may do genetic testing. First of all, endometrial cancer broadly classified in two major subtypes, different clinical pathological characteristic and risk factor. Type 1 endometrial cancer and type 2. Type 1 endometrial cancer is low grade. FIGO classification into grade 1 and grade 2, associated with more than 80% of all cases of endometrial cancer. But type 2 endometrial cancer, it is high grade by FIGO classification, it's a grade 3, and less than 20% of all cases of endometrial cancer. In type 1 endometrial cancer, present at early stage, estrogen sensitive and has good prognosis, but type 2 high-grade endometrial cancer always presented in late stages, non-estrogen sensitive with bad prognostic features.
And again, this is the historical
classification.
Okay.
We are now
Marco is going to update this classification and at the end of the presentation, yes.
Historical classification, estrogen dependent or non-estrogen dependent. Type 1, the most common again among endometrial cancer, 80%. Type 2, the less common, 100%. Among the age of the patient, most endometrial cancer, its peak presence is 60 and 70 years, but 2 to 5% of the cases are occurred before the age of 40. These patients have a state of chronic anovulation or chronic estrogen exposure without unopposed progesterone exposure. So most common ages among 60 up to 70 years. Personal history of the patient, the female come with a morbid obese patient, early menopause or has late menarche, has chronic state of anovulation, may be on chronic tamoxifen intake, with family history of endometrial cancer or either colon cancer, what's called Lean syndrome, I will talk about it, or may have thyroid or breast cancer, what's called Cowden syndrome, or may have BRCA carriers. Clinical presentation of the patient may come at early stages, abnormal uterine bleeding, may associated with anemia, so may have pallor, associated with pelvic pain or vaginal discharge. But in late stages, have abdominal distension, may have associated with pelvic mass, or symptoms of peritoneal disease, up to intestinal obstruction, or up to metastatic stage of lung and metastatic. Abnormal uterine bleeding. Always endometrial carcinoma typically present with abnormal uterine bleeding. Present within 55 to 90% of cases. And we should consider any postmenopausal bleeding is suspicious for endometrial cancer.
So Marco, this is something that we consider very good and very bad in the same time. As we have finished the ovarian cancer module, most cases are presented late in stage 3 and 4 because the ovaries are small organs in the abdomen and they present late with all these non-specific symptoms of GIT and urology. For abnormal uterine bleeding, this is a very early sign, so we can detect the endometrial cancer and we can pick up the cases early. So this is a good thing. But the bad thing is that that's why we say that endometrial cancer cases usually are not referred to the specialized centers and to the cancer centers, because simply many general gynecologists who are faced with abnormal uterine bleeding, and they just do a bedside ultrasound or even without an ultrasound or even without examination, and they go directly, if the patient is postmenopausal, let us remove your uterus because of the bleeding. So this is a very important word, that any postmenopausal bleeding is suspicious for endometrial carcinoma. This doesn't mean that all postmenopausal bleeding is due to endometrial carcinoma. And it is not the most common cause of postmenopausal bleeding.
The
It is
most
not
common
special.
is typical endometrial hyperplasia.
And atrophic vaginitis.
Okay.
Atrophic vaginitis is the most common. So the atrophic vaginitis and endometritis are the most common causes of endometrial. But again, it's a red flag. Any bleeding in cancer is a red flag. So if you have, for example, hematemesis, this is a red flag for gastric cancer. It may be an ulcer, it may be varices, it may be gastropathy, gastritis. But any bleeding is a red flag to exclude cancer. So please, the message for our dear general gynecologist, don't ever proceed easily to simple hysterectomy or, of course, the shit of the total hysterectomy due to postmenopausal bleeding. You should investigate your patient to exclude carcinoma first.
What we do next after the patient with abnormal uterine bleeding, we may do pelvic examination. Some sort of cases at early stage not typically have symptoms of any pelvic examination, but may involve the estimation of the size and motility of the uterus, may be direct infiltration of the genital tracts to exclude any other local causes of bleeding. And more advanced cases may be enlarged uterus or fixed uterus or fixed to other organ in the pelvis. We may do abdominal examination if it's associated with peritoneal disease, or maybe there's associated nodal infiltration and inguinal infiltration. Radiological investigation. What is the most common sensitive investigation for pelvic lesions? We should do first, most common sensitive is pelvic MRI. Yes. But with what is the first investigation to do? TVS, transvaginal sonography.
Yes.
What is the role of imaging of endometrial cancer? First of all, to comment on myometrial invasion. If there's more 50% of the myometrium infiltrated or not. If associated with positive lymph node radiologically or not. If associated with unresectable disease, peritoneal disease, associated with advanced stages fixed to the surrounding rectum or bladder, the role of imaging for endometrial cancer. First investigation is transvaginal sonography. Advantage is a non-invasive method to evaluate the patient with postmenopausal bleeding at all. aim measurement of the endometrial thickness. We comment على postmenopausal patient. If patient with postmenopausal normal endometrial thickness not more than 3 to 4 millimeter. But if more than 5 millimeter with no endometrial bleeding, the risk factor for endometrial carcinoma should be considered. So TVS with endometrial bleed thickness more than 5 millimeter, indication for endometrial biopsy, if associated with abnormal bleeding or not. Asymptomatic patient with endometrial thickening. Meta-analysis done among 32 studies, including 11,000 asymptomatic postmenopausal patient, not using hormone therapy, endometrial thickness was about 2.9 millimeter. So second endometrium be incidental finding on ultrasound examination. So الendometrial thickness أكتر من more than 5 millimeter, sensitivity up to 83% of patient detecting endometrial carcinoma lower than in symptomatic patient. The second investigation is MRI. MRI is more sensitive than the transvaginal sonography to comment on the depth of myometrial invasion if associated with cervical invasion or nodal metastasis. Dynamic MRI enhancing is also best tool to assess tumor extension to the cervix. We will differentiate between the presence of deep myometrial invasion for more superficial involvement. SCT, not sensitive for endometrial carcinoma, but assess abdominal extent of the disease if associated with iliac or aortic lymph node, if associated with extraterrine extension, if it is more advanced disease, or we are planning for neoadjuvant treatment before doing surgery. PET-CT is still questionable investigation for the early assessment of endometrial cancer. Good prognostic value in advanced stage. Routine use is still questionable. Not routinely used, not should we encourage the use of PET scan.
So next week, we are going to, the whole presentation next week is going about imaging of endometrial cancer. Dr. Gehad Saleh, she's one of our eminent radiologists here in OCMO. She's going through details, but for our dear oncologists who are online, and I see many on board with us physically and virtually as well. Okay, the gold standard in endometrial cancer is TVS by experienced hands, okay, or pelvic MRI, which we are going to discuss next week, either post-contrast or diffusion-weighted MRI. There is no rule for CT except for extrauterine disease, but we need seriously the MRI for myometrial thickness, myometrial invasion, and the degree of myometrial invasion to see what we are going to do as surgeons. Are we going to do lymphadenectomy, omit lymph node, sentinel lymph node, something like that? So please don't rush, because sometimes when case of endometrial cancer, go to the oncologist first rather than a gynae oncologist or an oncosurgeon. They order CT, and then they come back to us and we ask them for a pelvic MRI. And the patient said, I have done CT, why to do pelvic MRI? And the thing that we discourage significantly is the use of PET-CT. There is no rule for PET-CT, especially in type 1 endometrial cancer. So there is no rationale at all or no justification to do a PET-CT in a stage 1A or 1B type 1 endometrial cancer. So for example, I see many times with general oncologist, a case that they have a DNC bleeding, she has DNC, so it is low-grade endometrioid adenocarcinoma, so they go first to the oncologist rather than to a gynae oncologist or a surgical oncologist. And so the oncologist usually, like they do in pancreas, in stomach, in sarcomas, they ask for a PET-CT. Why? Why? The incidence of extrauterine disease in low-grade endometrioid adenocarcinoma is very, very limited. And so you just delay the diagnosis of your patient. The cost in a limited resources setting, which is I emphasize usually in Egypt, the cost really is heroic, either in the insurance-based or on the private base. It is heroic for the country. And again, when the patient come back for you, you will order again MRI, and the patient will not be happy with all of us, with the oncologist, going to cost everyone. So please forget PET-CT, except in stage 3 or 4 serous carcinomas and high-grade, high-risk pathologies.
Third step of diagnostic investigation.
So we had the clinical, which is mainly the bleeding, and we had the
Investigation.
radiology, which is mainly TVS and MRI. Yes.
Third step for diagnosis is a histopathological diagnosis. We need a biopsy from the endometrium. 3 types of biopsy. Office board endometrial biopsy, I have not done before, or diagnostic cystoscopy and biopsy, dilatation and curettage.
Office board is very easy. Biopsy is it's very easy. I have many pebbles. If you want, I can bring you some.
You have done before?
Yes, several times.
Pipal endometrial biopsy, advanced minimal invasive technique, no need for cervical dilatation, just local or no anesthesia is required, performing on an office technique. Disadvantage, lesion may be missed, or patient discomfort may be associated with uterine pain, rarely very to associate with uterine perforation.
ده عايز واحد غشيم قوي عشان
I have only seen this video. I may explain. Okay.
Your
First
doctor will
done
first do a
dilatation, then
manual
insert
exam
the pipal
to
instrument.
determine the position of your
Be just
uterus,
suction technique. That's what I have understand
then
from the
place
video.
its speculum in your vagina to open it up
Suction.
and keep it
Yes.
open so
Okay.
the cervix is visible. Your doctor may use another instrument called a tenaculum to grasp the cervix and hold it steady during the procedure. Your doctor will then pass a long, thin, flexible tube called a pipelle through your vagina and cervix and into your uterus. The pipelle is equipped with a piston-like
Very high
device
risk of
that
missing
creates suction when full.
Yes.
Your doctor will spin the
But it's a
pipelle
nice
and move it up
office.
and down in the uterus
Yes.
while
Dr. Said,
suctioning
they
up
already
an
like it so
adequate
much.
sample of
And he diagnosed many
endometrial
cases with it.
tissue.
I see
Then
many cases
remove
diagnosed
the
to
pipette
side with
and
pipal.
place its contents in a container. Your doctor will
5 times 2 suction the recoiling. To make sure you take all the borders 5 times. Okay.
I was telling Dr. Marco in في الoffice pipette ده الoffice pipette we take it 5 times and while you're doing the procedure you rotate the pipette while you're extracting it through the way عشان كده you take samples from all the levels من الفندس near the cervix.
Thank you, doctor. The second method is DNC, dilatation and curettage. Advantage, if patient can't tolerate an office biopsy, after non-diagnostic office biopsy, we will proceed for DNC. TVS suggests suspicious mass, either polyp or can't be excised or can't be biopsied by the pipal biopsy. If the patient will have benign histology, resistant abnormal twin bleeding, we need another confirmative biopsy by DNC. This is also for the video for dilatation and
Your doctor
curettage.
will insert a speculum into your vagina.
Here is this
widens
video.
the
He used a
vaginal
hysteroscope before
so the
doing
cervix can
the
be seen.
curettage.
Casco.
During dilation, your doctor will insert a
no, but
series
you
of
take it.
smooth rods into the cervical opening. Each rod will be replaced with a slightly thicker rod, thereby slowly widening or dilating the cervical opening so the inside of the uterus can be accessed. Once the cervix has been expanded to about 6 to 9 millimeters, your doctor may perform a hysteroscopy, a procedure in which a small light and camera are used to examine the inside of the uterus for abnormal areas. Next, your doctor will perform curettage, which is the surgical removal of part or all of the uterine lining, called the endometrium. During curettage, a surgical tool called a curette will be inserted to remove tissue by scraping or suction. If you are having a diagnostic DNC, your doctor will remove only a small sample of the endometrium and send it to a lab to test for various conditions. If you're having a therapeutic DNC, your doctor will remove the entire contents of the uterus to treat a known uterine condition.
And of course, this is Marco because this is a 2011 video. But now, if you put the hysteroscope and you find any suspicious lesion, you would use the resect it with using the hysteroscope, never to remove the hysteroscope and then do DNC. So we'll do everything with the hysteroscope rather than removing the hysteroscope. But this
You will
is
teach us
this is 13 years old video.
You will
But it's
teach
a
us
good one.
hysteroscope. Disadvantage of dilatation and curettage, patient in need of general or spinal anesthesia, may be associated with unexpected hemorrhage, may risk of uterine perforation, and there is risk of anesthesia and hospital admission at all.
I usually do it with sedation, not without
Sedation,
intubation or
oh.
without, just with sedation and laryngeal mask.
Sorry for that. You may also miss a lesion at the isthmus, at the corners of the uterus, can be missed in DNC.
Without hysteroscope. Diagnostic hysteroscopy and or be therapeutic. The advantage is associated with direct visualization of the endometrial cavity, avoiding lesion, as your doctor said. May be curative if associated with single polyp or benign lesion. Associated with, may be helpful in fertility sparing cases and detect any abnormal growth of the uterus. This advantage also associated with spinal or general anesthesia, more skillful surgeon. Assessment require more skill and more costly and invasive techniques than other DNC. Maybe associated with flushing of fluid or air. If associated with perforation, maybe lead to peritonitis. This is a histoscope like the before.
Your
But-
doctor will begin by inserting a speculum to spread open the walls of your vagina. Your doctor will then pull the cervix toward the entry of the vagina. Next, your doctor will use instruments called dilators to open up your cervix. Your doctor will guide a hysteroscope, a thin device equipped with a camera and light, through your vagina and into your uterus. The camera transmits images of your uterus to a screen. Your doctor will inject gas or fluid to expand your uterus, making it easier to locate abnormal tissue in your uterus. In a diagnostic hysteroscopy, your doctor will use the hysteroscope to examine the inside of your uterus. In an operative hysteroscopy, your doctor will insert small tools through the hysteroscope to take a biopsy, remove a growth, such as a polyp, or treat other problems.
Laboratory investigation for endometrial cancer. CBC, normal investigation, CBC, liver, tumor markers. What about tumor markers? Tumor markers always have no rule for diagnosis of any cancer, but it's a good indicator, good prognostic factor for follow-up of the cancer at all. At endometrial cancer, widely used cancer antigen 125, CMA 25, and recently human epidermis protein 4, is more sensitive than CMA 25 in early stages of endometrial cancer compared to cancer antigen 125. Type 2 is serous, non-endometrioid origin.
يعني الجنرال انه نو تيومر ماركر فور اندوميتريال كانسر اصلا،
Okay.
بس ممكن تايب 2 اللي هو
Non-endometrioid
الهاي
origin.
ريسك ممكن يكون سي ام 25 بيكون فيهم elevated مع الكلير سيل او سيرس.
But not as diagnostics to
But what's C125 will mostly be يعني elevated if you have peritoneal disease. فبدأ يتروح peritoneum sometimes in serous and clear cell, yes, but mostly if you have peritoneal disease and it is not usually used routinely for diagnosis. But I ask for it just for research and for interest. Sometimes when it's high and then you search for peritoneal disease, you find it's stage 3 or stage 4 when it is significantly high, or you can have synchronous, ovarian endometrial carcinoma as well.
Okay.
I use it مش هنخسر حاجة يعني، بس it is not recommended routinely يعني.
We talk about syndromes associated with endometrial cancer. Lean syndrome.
HE4 is human epididymal factor 4. Human epididymal factor 4, it is used as a tumor marker equivocal or to C125 in ovarian cancer. Usually they use C125 and HE4. It is used in many institutional worldwide, but it hasn't gone so publicity. We use it sometimes in the National Cancer Institute, but it wasn't that famous like C125. But it is used for ovarian cancer mainly.
Syndromes associated with endometrial cancer. Lean syndrome. Endometrial cancer first malignancy in 50-100% of women with Lean syndrome. Associated with gene mutation, autosomal dominant gene, germline mutation according DNA mismatch repair pathway. Patients with Lean syndrome have about 71-100% lifetime risk of developing endometrial cancer compared to 2.7% in general population. So patients with Lean syndrome should be investigated for endometrial cancer. Another syndrome, Cowden syndrome. Patient with breast or thyroid cancer may be associated with autosomal dominant gene mutation, BTN tumor suppressor gene. This is a high risk of uterine myomas, is a risk of endometrial cancer besides thyroid with breast. But this is symptomatic. But about genetic classification and molecular classification of endometrial cancer. BRCA carriers may be associated sometimes of BRCA carriers, but not well proved in the patient with BRCA carriers have risk of endometrial carcinoma. This is the recent classification of endometrial cancer, depend on molecular subtyping, and has prognostic effect about the type. Cancer Genome Atlas, atlas for all cancers, have classified endometrial cancer into many subtypes according to gene mutation. multiple gene defects, multiple gene mutation, but there is only 4 molecular subtypes have been classifying endometrial cancer into these 4 subtypes and its prognostic effect. Polymerase mutated and in microsatellite instability and copy no low, the endometrioid like, and what's called copy number high, the serous like. What is the difference of this molecular classification? There is a defect in genetic mutation of such a group of patient and has prognostic factor effect about this patient. So if the patient with endometrial cancer had been investigated for genetic molecular classification and have been polymutated or ultra mutated, this mutation, high mutation rate and has hotspot mutation of polymerase gene, this was called high grade endometrioid carcinomas, which is the best prognosis for endometrial cancer. If it is hypermutated or microsatellite instability, that has mutation of what's called the gene MLH1 promoter gene. This is endometrioid endometrioid cancer, the Lynch syndrome associated, the intermediate prognosis. If it's associated with low copy number abnormalities, this is microsatellite stability, MSS, the microsatellite instability, the endometrioid carcinoma. It is also intermediate prognosis. But the worst prognosis has the B50C mutation, the high copy number abnormality. This is the serous non-endometrioid type, serous high grade and mixed carcinoma. It is the worst prognosis. And this will be more illustrated by Dr. Basil after 2 weeks by Dr. Basil. Thank you.
So thank you, Dr. Marco. Yes, we are going to do next week the imaging in details, all about the MRI, the CT, the TVS with Dr. Gad Saleh. And the week after, I'm going to speak about the molecular classification in details and its implication on the clinical practice, how the whole process ازاي وصلنا للنقطة دي دلوقتي في molecular classification. And then after we are going to have the surgery for endometrial cancer with Dr. Khaled Gaballa, and then next we are going to have adjuvant treatment. And this is the answer for Dr. Fatma Faragalla. She is asking معلش هي المحاضرات دي بطنة أورام أو جراحة أورام هل المحاضرات دي the good thing about our lectures Dr. Fatma, our course, it is multidisciplinary. It is for gynecologists, for oncosurgeons, and for medical and clinical oncologists as well. So for example, today lecture by Dr. Marco will be relevant for everyone. The radiology one will be relevant for everyone. Khaled is going to speak about surgery in details, so it is for surgeons. And then after that, Dr. Fatma Izzat from clinical oncology is going to speak about adjuvant treatment and metastatic and recurrent. So it is a multidisciplinary for everyone who is interested in gynecology. So thank you, Marco, so much. To summarize, we have a clinical, a radiological, and pathological diagnosis. The clinical is mainly the bleeding in the early stages, and then you go for the biopsy. The biopsy, the best is hysteroscope, but you can go for DNC, and then you can go little even for Pebble biopsy, office biopsy by Pebble biopsy. And then after having, before the biopsy or after having the biopsy, you can have TVS or MRI. Those are the gold standard. We are going to speak in this in details next week, okay? TVS or MRI, and then CT or PET-CT for staging and for things that if you need. And again, please don't use PET-CT in endometrial cancer. We are waiting for questions from the audience, either those who are live or are physical with us or are virtual. Dr. Amira.
Thanks, Dr. Marco. It used to be in the gold standard for imaging and CT, صح? For endometrial. Cervical was MRI, or endometrial can CT.
MRI.
No, again, MRI is the gold standard for imaging of the pelvic organs. As oncosurgeons, this is the gold standard in rectal cancer, in prostate cancer, again, and for cervix endometrium. Because our surgical decision is based mainly on myometrial invasion, okay? And to see and to delineate between the uterus and parametrium and the bladder and rectum, this is very difficult with CT. Just the delineation of all pelvic organs is done best with MRI. So whatever you are in the pelvis, the gold standard is MRI in gynecological cancers and non-gynecological cancers as well. This is going to be in details with Dr. Gihad next week. And again, it's a post-contrast MRI, or if you don't want to have a contrast, it's diffusion weight. CT really has no role, even I believe in all type 1 endometrial cancer, endometrioid, low grade and intermediate grade. There is no rule for CT. You have another question, Dr. Sahar?
It's a comment rather than a question. Thank you, Mark, for the lecture. I like the videos. This is a great effort. Thank you. The point is, although the commonest cause for postmenopausal bleeding is atrophic vaginitis and endometritis, yet we have to exclude other causes, mainly CA endometrium. I do agree with that. My question is, if I'm having an endometrial thickness that is less than 4 millimeters, less than the cutoff level, and the patient presents with a bleeding, am I going to take a biopsy or not? Thank you.
الدين بيقول ايه؟ So
أعمل
sure. What Marco has said,
Perforation.
symptoms equals biopsy. Okay, so if you have bleeding, you have to exclude. Okay, and let's go to the ground, to what we see every day. Again, if the patient comes with postmenopausal bleeding, the most common cause is atrophic vaginitis or atrophic endometritis, and then maybe endometrial hyperplasia, either typical or atypical, and then endometrial carcinoma may come later after that. But first, my dear gynecologist, examine your patient, put your finger and do a PV, please. ماشي? Put the speculum and look at any cervical ulceration or cervical erosions or something like that. And do, if you must be competent enough in doing an office ultrasound, okay? Exclude endometrial carcinoma, because what we see from everyday practice is some patient come with bleeding, postmenopausal bleeding, either with normal thickness, okay, or just a missed mass, or just myomas. For example, myomas, like if you find a mass in the uterus 4 centimeter or 3 centimeter in a 65 years old lady, it is not the age of uterine fibroids or myomas. You have to exclude cancers. And if you are not experienced enough in doing the ultrasound, you can say, oh, this is a myoma and I'm going to do a hysterectomy. So what we say every day, the decision of doing a hysterectomy is a very fast decision from the clinic. Just you see your patient, you examine, or even you don't examine, you don't put your finger in her vagina, you just use the ultrasound, and then you decide to do a hysterectomy the next day or in the same day. And more, it's usually, or not usually now, but it is not infrequent to do a subtotal hysterectomy. And then we in the cancer center receive every week a case of endometrial carcinoma with subtotal hysterectomy, either with positive or negative margins. And much more and more crazy is we're receiving subtotal hysterectomies with the cervical cancer, just in the biopsy and leaving all the cancer behind. Okay? This is not acceptable at all. Really, this is not acceptable, and we can't go for more of this. So we don't recommend subtotal hysterectomy at all. Even with all the precautions that our colleagues say in Egypt, don't do subtotal hysterectomy. And I can do this وضميري مرتاح. Okay? And again, you have to examine your patient. Rushing into hysterectomy endometrial carcinoma is a very indolent disease. You can, if the patient has endometrial cancer, you can do a hysterectomy after 1 month. It is safe. Okay? So don't have bleeding. Have the decision of doing a hysterectomy just today or next day. قبل ما يجي الجمعة مش لازم يجي عليك الجمعة بالكلام ده.
And the need of biopsy. So we have seen a patient in
Yes.
our center doing a hysterectomy for bleeding, but
Yes.
postoperative high-grade endometrial cancer, but she has total hysterectomy without effect.
Yes, again, I have to, today, this discussion was one of my patients, okay, that she came with biopsy, high-grade serous carcinoma, and then again, Dr. Khalid Gawala is going to say this in his presentation. The surgical decision is different according to the pathology. So what's usually said to the lady, that you have bleeding, you have endometrial thickness, كده هنعمل لك hysterectomy, you are going to have hysterectomy anyway, okay, so we don't have to put you twice in the OR to have biopsy and then to have operation. This is a very usual conversation that we hear every day. And again, you have to say to your patient, no, please, because treatment of low-grade endometrioid carcinoma is totally different from carcinosarcoma or from high-grade serous or clear cell. So we have to have either biopsy, okay, or sometimes frozen section, but even frozen section is not the standard. But don't rush to do a hysterectomy. Forget the subtotal hysterectomy. I'm going to kill those who do this, okay? But don't rush to do hysterectomy for a patient 70 years old or 65 years old without adequate counseling and biopsy, and just relax before taking this decision. So we had a comment from Amira and Sahar. We should have a comment from Amr.
Thank you, Dr. Marcos.
Thank you.
I know that most of patients are postmenopausal and presented by abnormal uterine bleeding. If the patient have risk factor as Lynch syndrome or BRCA, there is a recommended screening program, especially from oncosurgeon side.
ارد انا برضو.
يا باشا.
حاضر. For BRCA mutations, the main cancers are the breast cancer and ovarian cancer. So if you do something for the BRCA, you are not going to be concerned with endometrial carcinoma. For Lynch syndrome too, the main concerns would be about colon cancer. Okay, so you are going to do frequent screening for colon cancer, but you are not going to do screening for endometrial cancer. But you can do like examination or transvaginal or something like that. But the screening mainly for Lynch syndrome is for colon cancer. Okay.
Screening program for
No
endometrial
screening
cancer.
programs for endometrial cancer up till now. Okay, but for Lynch syndrome, you should exclude endometrial cancer. You should exclude endometrial cancer in Lynch syndrome if you have MSI. دكتور هشام ابو طالب شخصيا موجود ورافع ايده. دكتور هشام يعني انت كده لازم ترتعش. استاذ دكتور هشام ابو طالب، اتفضل يا بروف.
اهلا وسهلا بكم جميعا. انا سعيد
بالراحه على
جدا رغم ان
ماركو،
انا
بالراحه على ماركو.
لا بالعكس، انا سعيد جدا بالدكتور ماركو، ربنا يزيده علم ان شاء الله. هو بس انا دخلت في الاخر، فانا ليا تو كومنتس بس. اول حاجه بالنسبه للسؤال بتاع الدكتوره سحر، اللي هو لو عيانه بوست مينوبوزال بليدنج وهل هنعمل لها بايوبسي وحتى لو الاندوميتريوم ثين ولا لا. I think this is the ideal case that we can go for hysteroscopic examination. طبعا احنا لازم نمشي systematic بالهيستوري والاكزامينيشن والالترا ساوند، لكن احنا دايما بتبقى موضوع الهيستروسكوبي والهيستروسكوبيك جايدد بايوبسي بيبقى ديبيتابل، لان انت عندك ماس هتدخل ازاي. ممكن مش هتكلم على ان احنا ننشر الاندوميتريال كارسينوما ده، لكن بالفعل لما تبقى اندوميتريوم ثين، ده الايديال كيس ان انت تعمل هيستروسكوبيك اكزامينيشن وبايوبسي فروم اني سسبيشس ليجن. الحاجه الثانيه ان احنا بنواجه دايما العيانين اللي بوست مينوبوزال بليدنج اند وي ار راشينج towards hysterectomy even subtotal hysterectomy، واتفقنا ان ده تعتبر شبه جريمه، يعني ما كانتش جريمه فعلا. احنا عايزين ننشر ثقافه ان احنا وي كان جيت ان اوفيس
جريمه متكامله
بايوبسي. هو
الاركان مع
المريض
سابق
نفسه هو اللي
الاصرار
بيجي
والتعمد.
ويقول.
دكتور هشام، جريمه متكامله
اه
الاركان مع سابق الاصرار والتعمد.
ودايما دكاتره النساء هم اللي بيعملوها. الموضوع ان بتبقى المريضه تقول لك انا هتعرض لبنج مرتين، وانت كده كده هتشيل الرحم علشان خاطر البليدنج، واحنا بنرد عليها نقول ان المانجمنت اوف endometrial carcinoma is different even there are different types every type may have a different approach. لكن المريضه ممكن ما تقتنعش بهذا الكلام. فانا اتمنى ان احنا ننشر ثقافه
دكتور هشام,
الاوفيس
can we do it in
endometrial
English
sample.
please? دكتور هشام, because we have many non-Arabic speakers in our
Okay.
virtual
I
place.
hope that we can expand the culture of having an office endometrial sampling for cases that we face in our office or our clinics, for having a postmenopausal bleeding or suspicious endometrial lesions. This will save the frustration of having anesthesia twice, which may be claimed by the patient that we shouldn't do, and we have to rush to hysterectomy as a definitive solution for the case of postmenopausal bleeding. I hope that we can have a mission that we can cases with postmenopausal bleeding or abnormal uterine bleeding with suspicious endometrial lesions, that we can get office endometrial sampling. This, I think, will be the best solution in our settings that can save patients from having a hysterectomy for endometrial cancer cases that are not diagnosed before or diagnosed.
Thank you, Dr. Hisham, so much. It's our pleasure to have you with
Hello?
us on board, really. It's our pleasure to have you on board with us, Dr. Hisham. And Dr. Sahar is
Thank
thanking
you
you
very
too.
much. It's my honor.
And Dr. Sahar and Dr. Amira are asking
It's
for
my
the
honor.
acute workshop certificates, Dr. Hisham. They want the acute workshop certificate. Please send them the certificates. Okay?
Of course. Today I will send them to my mail. Please send me the emails to my WhatsApp or by mail, and I will send them directly.
Thank you so much. So, do we have any other
You're welcome.
comments from our attendees? Any questions? So, Marco, it seems that everything is clear now. So, again, Dr. Mohammed Zahiri, if he is still here, Dr. Mohammed, thanks for your presence always. Dr. Mohammed, thanks for your advice. Now we have finished the ovarian cancer chapter. We are going to do the endometrial cancer chapter when we finish it, and we are going to do the cervical cancer when we finish it. And all this presentation will be in a handout or an ESGO fellowship handbook for all residents and fellows and everyone interested in gynecology. He can have a handout of all our presentations when we finish the course, I believe by the mid of next year, 2025. So really, I'd like to thank Dr. Mohammed Zahiri, the ex-head of gynecology unit in the National Cancer Institute the National Cancer Institute in Cairo, about this advice to collect all the presentations in handbook for the residents. Thank you, Dr. Mohammed, and we are going on it. Thank you, really. Next week is going to be imaging of endometrial cancer, Dr. Gayad Saleh, waiting you next Wednesday at 9 p.m. Thanks, Marco, for the concise to the target presentation. Really, it was nice. And thanks for all our audience. See you next week. Bye-bye.